wanted to talk to you quick about this first case. It's a 42-year-old gentleman with multiple sclerosis. So he has relapsing remitting MS, but is fully ambulatory, still very high functioning and completely healthy otherwise. So he has no other medical problems or medications. His primary complaint when he was referred to me was incontinence with urgency, as well as a slow stream when he's voiding. On exam, everything looks pretty normal. He doesn't have a large prostate or anything, and his post-void residual was 120 milliliters when I checked it in the office. So because of the MS, I thought we should probably do urodynamics to get a better sense of how his bladder's working. And I'll show you a picture of what the urodynamics look like. But essentially, we did a filling cystometrogram, and at a volume of about 170 centimeters of water, he developed neurogenic detrusor overactivity. How often do you find you see neurogenic detrusor overactivity in your MS patients?
Well, actually, it's the most common finding. However, MS patients are also kind of population that sometimes present with very severe urgency, but you don't find anything. So it's a bit a mixture. So if we find something, it's usually DO, but sometimes we recognize in the standard filling cystometry, we don't see DO despite their strong symptoms of urgency.
Yeah, no, it's always something that's challenging. It's nice when you see it, but then when you don't, you kind of wonder if it's still there, and you just have to keep repeating the tests. Do you usually do 2 fills for most people with MS, or?
Yeah, it's a standard that we, in the neurogenic population, we do the repeat session urodynamics to really verify our findings, to really see what is the worst finding and that we need treatment or not to really justify treatment. And often we see that in the first filling cystometry, you may not see detrusor overactivity, but you see it in the second, so it can really change. And also in some patients, if we really do see nothing, despite their symptoms of urgency, we use the ice water test because it's a kind of provocation. Certainly, it's not physiological, no doubt about that, but it can help you to distinguish a bit how sensitive is the bladder reacting to the provocation, and can be at least there be a sign hidden that explains you the strong urgency symptoms in daily life.
So in this one, I was kind of lucky. I showed the neurogenic detrusor overactivity on the first fill of the CMG there. So this is always a patient that I struggle with. And that's why I wanted to get your opinion on things. So he has neurogenic detrusor overactivity, but at the same time, he has symptoms of voiding dysfunction. So he's got a slow stream, and he doesn't feel that he's emptying well. And I mean, you don't see many 40-year-olds with a post-void residual, of 120 already. So how do you manage the balance between helping his storage symptoms while not making his voiding symptoms worse?
That's a tricky question, because that what I also see, that is the main problem in MS patients, that they usually have a combined problem. And of course, that's a big discussion you have to have with the patient on what he wants to do, because very often and in many guidelines, you see intermittent self-cauterization as one of the first treatment options that you offer to the patient, sometimes even before you do detrusor sedation therapy with an antimuscarinic, because they steal their own capacity because they have so much residual. So if he is not happy to talk about intermittent self-cauterization or be trained in that, and you want to keep him on normal voiding, then you can try as a first therapy a kind of neuromodulation. It doesn't mean that it needs to be directly sacral neuromodulation, which is invasive, but you could try percutaneous tibial nerve stimulation as an example, if that helps for that patient, to give it a try, because that doesn't compromise normal voiding through the urethra.
I think that's a great option. And unfortunately, in Canada, it's mostly an academic option. We don't really have access to any percutaneous tibial nerve stimulation devices here. I'm hopeful some of the new implantable ones will be approved and marketed here in the near future. What would you say in terms of medication? So would you start with treating his voiding dysfunction? Do you think that'll help his storage symptoms, or would you start with treating his storage symptoms and then move on to something for his voiding dysfunction down the road?
Yeah, that depends a bit what is also the leading symptom and how often you have measured the residual volume. So you would have to have several flows to get an opinion. Is it always like 200, or is it like exceptional one time 120, and usually it's on average it's about 70, and it depends also on his total capacity. So if that is only a minor problem, I would certainly go for treating his storage symptoms and start with an antimuscarinic. And then see if his residual volume, post-void residual volume, increases significantly. If not, and his symptoms get better, then you're on the right way.